Welcome to Introduction to Healthcare and Public Health in the U.S. Meaningful Use. This is Lecture B. This component, Introduction to Healthcare and Public Health in the U.S., is a survey of how healthcare and public health are organized and how services are delivered in the U.S. It covers public policy, relevant organizations and their interrelationships, professional roles, legal and regulatory issues, and payment systems. It also addresses health reform initiatives in the U.S. The objectives for this unit, Meaningful Use, are to define meaningful use, or MU, of health information technology in the context of the Health Information Technology for Economic and Clinical Health, or HITECH Act. Describe the major goals of meaningful use. Discuss the criteria for stages 1 to 3 of meaningful use for eligible professionals, eligible hospitals and critical access hospitals, describe the standards specified for MU, and discuss the likely evolution of the MU program. In this lecture, we will continue our discussion of the HITECH Act and achieving meaningful use. We will discuss how the Meaningful Use program has been operationalized, with the warning that there is a great deal of detail included here. It's most important, though, to keep your eye on the big picture. In the Meaningful Use program, recall that there are eligible professionals, eligible hospitals, and critical access hospitals, and that they need to meet 3 requirements to receive reimbursement funds. One requirement is meeting the meaningful use objectives in the various stages. In the original stages 1 and 2, each had 2 sets of objectives. The first set of objectives were the core objectives. All of the core objectives had to be met. For the second set of objectives, users could choose a required number from a larger menu of options. Recently, Stage 2 has been modified to have only core objectives. In addition, the criteria for Stage 3 have been released. In this new setup, those seeking remuneration via the Meaningful Use program must meet all of the objectives. There are no choices. In addition to meeting the meaningful use objectives, there are clinical quality measures, or CQMs, that had to be met as part of the 3 requirements. In the 2011 release of the original CQMs, there was one set of CQMs for eligible hospitals and another for eligible providers. These were superseded in 2014 by expanded sets of clinical quality measures. No matter what stage an EP or EH was in, starting in 2014, all those seeking remuneration through the Meaningful Use program needed to meet the new clinical quality measures. The third requirement for qualifying to receive Meaningful Use reimbursement funds was meeting standards designated by ONC via Certified Electronic Health Records. The original Stages 1 and 2 were announced in 2010 and 2012, respectively. The program started making payments for Stage 1 in October 2010 for eligible hospitals and in January 2011 for eligible professionals. Stage 2 was delayed a year from its original start date and began in 2014. The Stage 2 objectives were announced in 2012 and raised the bar on many of the objectives. There was also additional emphasis on patient engagement and health information exchange, or HIE. Here's another way of looking at Stages 1 and 2. Each of these stages had its specific objectives, the standards that needed to be used to achieve those objectives, and the clinical quality measures, both the original CQMs and the 2014 update. In 2015, the rules for Modified Stage 2 and for Stage 3 were released. Modified Stage 2, in essence, combined the original Stages 1 and 2, so any EP or EH just starting down the Meaningful Use road or still in Stage 1 now had to meet the objectives of Modified Stage 2 through 2017. Starting in 2017, eligible professionals and eligible hospitals can begin attesting to Stage 3. Today, there is some uncertainty over the future of the Meaningful Use program due to the Medicare Access and CHIP Reauthorization Act, or MACRA, that was passed by Congress in 2015. MACRA calls for combining all CMS quality programs, including meaningful use, into a single program, so it's possible that meaningful use will change further in the year or two ahead. But for now, this is how the stages of meaningful use must be met to become eligible for or maintain eligibility in the meaningful use program. We will talk more about the future of the meaningful use program at the end of the last lecture. As seen in the table on this slide, everyone already in meaningful use should be in Modified Stage 2. Those starting in 2016 and 2017 would start in Modified Stage 2. In 2017, they could actually start in Stage 3. By 2018, everyone should be in Stage 3, although this is all subject to any changes that might come from the MACRA legislation. Let's go back to the original Stages 1 and 2. In Stage 1, eligible professionals had to meet 15 core and 5 of 10 menu objectives. Eligible hospitals had to meet 14 core and 5 out of 10 menu objectives. These were essentially the same, although hospitals were not required to carry out electronic prescribing since they tended to prescribe within their hospital by their computerized provider order entry systems. It was also specified that for eligible professionals and eligible hospitals, one of the menu objectives needed to be a public health measure. In Stage 2, some of the measures were consolidated and some new ones were added. Now, eligible professionals had to meet 17 core and 3 of 6 menu objectives, and eligible hospitals had to meet 16 core and 3 of 6 menu objectives. Stage 1 requirements were achievable by most eligible professionals and eligible hospitals. Stage 2 requirements proved more difficult for many eligible professionals and eligible hospitals to meet. This slide shows the original core objectives for Stage 1 of meaningful use. You can see the various objectives such as recording demographics, problem lists, medication lists, and allergy lists. Also required was providing clinical summaries. Another requirement was using, to a certain level, computerized provider order entry or CPOE, implementing clinical decision support, carrying out a security risk analysis, and reporting clinical quality measures. This was the Stage 1 of meaningful use that the early meaningful use program participants had to achieve to get their first payments under the HITECH Act. This slide lists the menu objectives for Stage 1. The objectives common to both eligible professionals and eligible hospitals are at the top of the list. Then there are a couple that are specific to eligible professionals and another couple that are specific to eligible hospitals. Moving on to Stage 2, there were changes from Stage 1. Some objectives were consolidated, some objective thresholds were raised, and 7 objectives were added around patient engagement and health information exchange. One of the new core objectives required that 50% of patients or their authorized representative be given access to health information, and of those, 5% had to view, download, or transmit health information to a third party. For health information exchange, the certification process now required supporting the direct protocol of point-to-point secure transmission of information, and a new menu objective required the exchange of clinical care summaries for 10% of all patient encounters. As noted before, there have also been standards specified to achieve meaningful use. There were standards in the original Stage 1 of meaningful use, and then in the new Stage 2. The tables on this and the next 2 slides show the types of standards required for meaningful use. For example, the patient summary record had to use the Continuity of Care document, or CCD. The problem list needed to be in SNOMED CT. The medication list must be in RX norm. Diagnoses and procedures must be in ICD-10, and laboratory results must be in LOINC. Some of the prescribing functions use standards such as NCPDP and RX norm. The electronic submission for quality reporting required certain formats from CMS. There were also standards required for various public health functions, whether lab results, surveillance, or immunization registry reporting. For these, various versions of HL7 were required. There were additional standards for Stage 2. One concerned amendments to the EHR required to support HIPAA compliance, with the patient being able to supply information either in free text or scanned format that could be appended to the EHR. Another was the need for the encryption of data on end-user devices, such as computers and mobile devices. For the process of viewing, downloading, and transmitting to a third party, the EHR had to be able to transmit either an ambulatory summary or inpatient summary, and also had to include a log that would track the viewing, downloading, and transmitting, with the patient required to have access to that log if they wanted to view it. Finally, for transitions of care, there was a requirement for the ability to receive, display, and incorporate summaries, as well as to create and transmit them. Stage 2 also specified a common data set for the summary care record. This was the minimum amount of information that could be included in a patient's transmitted summary care record. The elements of the data set are listed on this slide. Stage 2 also introduced some privacy and security measures. One was specifications around algorithms for encryption and decryption, with any information transmitted through the HIE needing to be encrypted, and the sender and receiver needing to be integrity protected. Another rule was that all accesses and modifications needed to have certain information collected, such as the date, time, patient, and user. Also, various algorithms had to verify that information was not altered in transit. Another was that all disclosures, including treatment, payment, and operations or TPO disclosures, needed to be recorded as well. Modified Stage 2 consolidates many of the meaningful use criteria from Stages 1 and 2. The major categories are listed on this slide and the 8 slides that follow. Patient health information must be protected by appropriate technical capabilities. Clinical decision support must be used and applied to a group of priority health conditions, and CPOE must be used to a specified level. Also required is electronic prescribing, which means transmission of prescriptions electronically by EPs and of discharge prescriptions by EHs. Modified Stage 2 also requires the capability to carry out health information exchange for the summary of care record. Additional criteria include the use of certified EHR technology to provide educational resources to patients. Another Modified Stage 2 criterion is the ability to perform medication reconciliation. The Modified Stage 2 criteria also include providing patients with electronic access to their health information and the use of secure electronic messaging. Finally, Modified Stage 2 requires appropriate reporting to public health agencies. This concludes Lecture B of the Unit on Meaningful Use. To summarize this lecture, the original Stages 1 and 2 of Meaningful Use have given way to Modified Stage 2 for 2015 through 2017, and Stage 3 thereafter. Stage 2 of Meaningful Use added a number of standards, a common data set, and requirements for privacy and security.